Great. Welcome to a Facebook Live session at the Rutgers Cancer Institute of New Jersey and Robert Wood Johnson University Hospital, where today we will address the exploration of blood disorders with an emphasis on leukemia and lymphoma. My name is Dr. Andy Evans. I'm Associate Director for Clinical Services at the Cancer Institute of New Jersey and Medical Director of the Oncology Service Line for RWJ Barnabas Health. And my expertise is lymphoma, and I'm really glad to have Dr. Banerjee.
Right, and I'm Dr. Rajat Banerjee. I'm Chief of the Hematologic Malignancies Clinic here at Rutgers Cancer Institute of New Jersey. And my interests are both drug development, new treatments for leukemias and lymphomas, and also chronic lymphocytic leukemia, or CLL, which is actually the most common leukemia that we see in adults.
Fantastic. So we're really happy to do this, especially in general this time of the year. As you may know, September is Blood Cancer Awareness Month, so we thought that was important to obviously to do it during this time. Also tonight, we have an annual educational event that we'll be holding later tonight here on the grounds. You're actually welcome to come. That starts at 5 o'clock is a reception, and then 6 o'clock it's meant for patients, and it's going to talk about targeted therapeutics with an emphasis on immunotherapy. So again, welcome. And the format will be during this approximate remaining 18 minutes. About half of the time, we'll talk about some initial big picture topics in blood cancer disorders. And then we have some questions that were submitted ahead of time. And lastly, please feel free to submit any live questions that you may have for us. And we'll try to answer these live in the moment. So really just to start, Rajat, maybe at 50,000 foot, I think to really keep it simple, sometimes we hear the word leukemia, lymphoma. What do we mean by that? Are there similarities? Are there differences?
Sure. So when we are speaking about leukemia and lymphoma, we're talking about blood cancers for both of those terms, but it's really how they present. So when we think of leukemia, we think of a blood cancer where the cancer cells are circulating in the blood, and this can often be found by your medical doctor getting a routine blood count and seeing a very high white blood cell count, or occasionally seeing very low blood counts. Lymphoma, on the other hand, typically presents as swelling of our glands, which are our lymph nodes. They're sort of filters for our body, and the tumor cells grow in those lymph nodes, and they can be anywhere in the body, and they present as swellings. Sometimes if they're in the chest or the abdomen, you can't feel them. You may have other symptoms, and we see them on a CAT scan, but sometimes they may be obvious, like swellings in the neck. So typically how they present is how we differentiate leukemias from lymphomas. And there are many ways to diagnose them. So how would you go about working up a leukemia and lymphoma patient, getting that diagnosis?
Well, yeah, and it's exactly just to dovetail off what you said. It's obviously going to be a lot dependent on how's the presentation. And sometimes if it's in the blood, there are some initial blood tests that can be done where it's really kind of revolutionized is not just looking at it under the microscope, which hopefully we still do to look how the cells look under the microscope, but it's all about the what we call phenotype, where we can literally analyze what's on the surface of these cells. We call that the immunophenotype, and there's special tools called flow cytometry that have been around a little while. But what's really kind of pushed the envelope is looking at literally inside the cells, the so-called DNA and RNA, or the molecular analysis. Because we know, we haven't figured everything out, but we know certain leukemias, lymphomas, even multiple myelomas will express abnormally some of these genes that'll be upregulated abnormally, almost like a switch that we all have in the body that should go on and off every day that's really just stuck in the on position. Another term for these is called an oncogene, is kind of what causes this. And just a lot of great research has been done over the last few decades. And I guess the silver lining of that, of knowing this science that we have in the bench, in the laboratories, including here at Rutgers CINJ, is it also gives us a target then, right, to treat, whether on the surface or inside the cell.
Absolutely. And so I think that, as Andy just said, there's been sort of a revolution in learning about what's driving these tumor cells, and in terms of treatment, being able to adjust our treatment to be more specific not only to the patient's diagnosis, but even more specific to the genetic changes that are in that patient's tumor cells. Although there are many examples of this, one example that comes to mind right away is a disease called acute myeloid leukemia, or AML. And many oncologists over many generations have treated AML exactly the same, because there were 2 chemotherapy drugs and we've been using them for 30 plus years. But in the last 5 years or so, there's been a revolution in understanding the genetic changes in AML, and now we have a number of new medications that are coming online that target some of these genetic changes, and we really focus our treatment on that individual patient's leukemia rather than just sort of a generic treatment that's one-size-fits-all. And that one-size-fits-all way of doing things is really fading into our rearview mirror.
And then Rajat, is that, so I think what you're kind of even getting at too is some of the terms, individualized medicine or precision medicine. When you hear that term, we hear it and it sounds good and we're getting better at it, but when you hear precision medicine, what's your quick reaction to that?
So my quick reaction to that is knowing the mutations that are driving a particular tumor and tailoring the treatment based on that genetic pattern and really individualizing it. There's a lot of work going on, obviously around the country in this field, but a lot going on right here at Rutgers Cancer Institute of New Jersey. And I wonder if you could maybe speak to some of the research going on.
There is, and it's really all aspects. And I think to me, that's where it's always privileged to be at a comprehensive cancer center. Because when we say, what does that mean? What is cancer research? It's really all phases, starting with what we haven't talked about yet of what causes this. So that's sometimes referred to as epidemiology or population health. So there's that aspect of research that we thankfully have really some outstanding researchers in that arena and really focus on the state of New Jersey. And there are certain cancers that are increased in the state, such as thyroid cancer. Actually, lymphoma, I don't know if you know this data, I was looking it up the other day. New Jersey has the 3rd most lymphoma diagnoses in the country per 100,000 patients in women. Men, it's a little less common. We don't know why, and I think that's important research. Of course, there's diagnostic research. We've talked a little bit about that. But what's obviously the most exciting is some of the therapeutic breakthroughs and that research of translating it literally across the street from where we're sitting right now. We're sitting near a clinical office, but right across the street are just a multitude of laboratories where we know there's ongoing, really sophisticated science that is looking at these markers and pathways. But we talk about translational medicine because what we want to happen is take those discoveries from the laboratory and bring it over here to the clinic. I know you have a passion of that, especially some of these early drug and what's called early drug discovery, because not everything pans out right from the laboratory to the clinic, and that's where clinical trials are helpful.
So clinical trials are a big part of what I do individually, but what the Cancer Center does. And they offer a number of advantages. First of all, sort of in the general societal sense of things, we're not going to advance treatment in cancers for us and for future generations without doing the clinical trials to show that certain medications work better than others, or new medications that work better than everything that came before. So that's one part of it. Another part of it is, we're doing much better in treating patients, and so patients may be feeling quite well and doing well for an extended period of time, sometimes for many years, and yet their leukemia or lymphoma comes back. So clinical trials also offer us as treating physicians and our patients the opportunity to access new medications that are still in the experimental stage. Some of them may pan out phenomenally, others may not, so there are unfortunately no guarantees, but it does give us kind of access to the cutting edge. And just taking 1 second in our own field of treating CLL, chronic lymphocytic leukemia, 2 of the major game-changing medications of this past decade or half-decade have been the drugs ibrutinib and the drugs venetoclax. And as a cancer center, we had those 2 medications available before we knew how well they worked in early trials. And so some of the first patients anywhere treated on those game-changing medications were treated here, and that's the value of research.
Yeah, I echo those results. And just the other too is yes, for patients unfortunately where it's relapse or refractory, but also in newly diagnosed,
Absolutely.
where we want to, yes, we still sometimes use chemotherapy, but it's a lot of times these studies in newly diagnosed is taking, okay, what's the worldwide standard? And then how can we make it better and even less toxic, often by substituting a targeted therapeutic. So I think we'll move on. Really, again, so the format is we had a few questions that were sent ahead of time. We'll go through those, and then I know there's already some live questions that are coming through that we'll address in the last 5 minutes or so. So one question that was sent ahead of time, this comes from @TomO'Rourke1 on Twitter. A really interesting question is, Dr. Banerjee, are there any breakthroughs with gene-altering drugs?
Right, so that's an interesting question, and I think if I take it literally, are there drugs that we can take that alter genes in our body, altering the DNA coding, changing the software? As far as I know, none right now in clinical use, but the concept is something that is actually exploding in clinical use, and so that is changing the genetics in the laboratory of some of our cells and then giving those back to us. And where we do it the most here in our field of hematologic malignancies is something called CAR T therapy, chimeric antigen receptor T cell therapy. And the easy way to look at that is we have white blood cells, immune cells that fight infections, that can find cancer in our body, but sometimes they don't recognize the blood cancer that's there and growing in the patient because the cancer has ways of hiding from the immune system. With this CAR T therapy, some of these cells are removed from the body, and in the lab they are genetically modified, where a gene is put in to recognize the leukemia cell or the lymphoma cell. Those cells, the patient's own cells with the new gene in them, are now grown in the lab, and then they're given back to the patient. And once they're in the patient, they circulate, they see the lymphoma cell or the leukemia cell that they've now been programmed to recognize and destroy, and they kill those cells. And there have been tremendous advances and successes with that kind of therapy, both in leukemia, specifically acute lymphoblastic leukemia of the B cell type, and also in a type of lymphoma that Dr. Evans treats a lot of called diffuse large B cell lymphoma. And there are studies with this technology in multiple types of leukemia and lymphoma.
Well, that's exactly what I was just going to say. So, like you just said, critical, really exciting breakthroughs recently with a couple commercial products. But is it fair to say we're just scratching the surface?
It is. Without getting too much into the science and down into the weeds of that, these cells and the potential of adding a gene in can be trained to target many different tumor markers that we call tumor antigens. And so there are just a plethora of studies going on worldwide, really, in training CAR cells to treat different types of leukemia and lymphoma beyond the two that I just said, and even some solid tumors.
That's great. That's great. And we'll talk a little bit more. I'm sure there'll be questions about immunotherapy that come through on the live feed here. Another just kind of big picture question, which sometimes is important and maybe we take for granted, where someone mentioned, if I'm diagnosed with a rarer type of leukemia or lymphoma, how do I know where to go to be treated? And what I would say, and in the state of New Jersey, the good news is there are a multitude of centers. And I think that's important to us because our director, Dr. Labudi, often says cancer does not travel well. And I totally agree. And at least in our health system, we obviously we feel like a really good operation and awesome teams here in New Brunswick at the Cancer Institute in New Jersey, but as part of RWJ Barnabas Health, it's 11 hospitals. And we've really spent a lot of time integrating these hospitals and trying to work together. So if a patient's in Monmouth or Jersey City or Newark or Livingston, Hamilton, Princeton, etc., we want patients to have the same access, and whether to technology, to treatments, to knowledge, as if they were right here at the Comprehensive Cancer Center. And so one slight shameless plug is our 1844 number. It's 1-844-CANCER-NJ. And the beauty with that number is it's an access to really, again, any of the hospitals and cancer centers in our health system. So that's one I wanted to go through on. So I'm going to move on. I just have to take a quick look at the phone in terms of questions that came through on the Twitter feed. So one question that came through, not Twitter, sorry, Facebook Live, is about stem cell transplants. And is that something, we've talked a lot about targeted therapy, and which is immunotherapy, and when we think of stem cell transplants, are we done with stem cell transplants, which often is high-dose chemotherapy? Is that still something we use?
So the short answer is yes, and actually our stem cell experts are neither of us, but they're just around the corner in the hallway. But we have a very active bone marrow transplant, stem cell transplant program, and they use various regimens, some very strong chemotherapy and total body irradiation, some that they call reduced intensity conditioning, not so strong, and in fact there are transplant techniques that they use where a lot of the work can be done as an outpatient. There are still scenarios for many of our diseases that we treat where a transplant is a part of the treatment regimen, some more than others. So a disease we have not spoken about a lot here, multiple myeloma, transplant is still a backbone of therapy for that disease. There are other diseases where transplant used to be very common, like chronic myeloid leukemia, where because of these targeted therapies, we don't need to transplant as many patients with that disease as we used to. So it's a kind of a moving target, but we have a very active transplant program doing both types of transplant, autologous transplant, where the patient's own cells are used for the patient, or allogeneic transplant, where a donor, another person's cells, are given to the patient.
That's right, and it's really case-by-case basis, right? Transplant's not a one-size-fits-all, whether it's autologous, allogeneic, who and when should receive that. So, and I think that dovetails into one of the questions, and we've maybe already touched on that, is if I'm being treated for a blood cancer with standard therapy, and there are some good standard therapies, should I still think about a clinical trial? And I think some of the question, because, well, does that mean experimental? And you've touched on that already, but something that's well established, do clinical trials still have a role?
So the short answer is yes, absolutely yes. And sometimes the clinical trials in patients who are newly diagnosed and are being offered the standard therapy, those clinical trials can really change the face of how a disease is treated. So in those situations, we may have some very good therapy, as Dr. Evans said, in terms of outcome. But there's still research going on in those fields, and Dr. Evans is an international expert in one of those fields, which is Hodgkin's lymphoma. We do a great job curing patients with Hodgkin's lymphoma with the standard chemotherapy. So where's that research going? It's looking at the small group of patients with high-risk disease, but it's also looking at the larger group of patients felt to be very curable, but now can we cure them with fewer side effects as they're getting treated and fewer long-term side effects, because we expect them to have many decades of healthy life ahead of them. And maybe you can address some of those first-line types of studies.
Yeah, I can, and because maybe one last question, and we'll kind of wrap it up with this last question, is what kind of research advances are being made for leukemia lymphoma? And I think it's a good question. We've touched on a lot of that, and it really kind of harkens back to what you were mentioning initially of what's on the surface of a cancer cell, because we can design antibodies or targets. They're still intravenous often, but again, unlike chemotherapy that just kind of kills anything growing fast in the body, these obviously are more targeted to that leukemia, lymphoma, myeloma cell, etc. But then also some of the other medications that, whether they're targeting the pathways that I talked about before, and you mentioned as well, and some of these are pills, like the BTK inhibitor or the BCL2 inhibitor, etc. And then maybe lastly, and it maybe kind of works in a little bit with CAR T cell, when we say immunotherapy, are these so-called checkpoint inhibitors, which you may know the receipt of the Nobel Prize was basically for that science behind that. And that's also related to the T cells and immune cells, where we know one reason patients will get cancer, and often a blood cancer, is the T cells aren't working. And these are medications that literally wake up the dormant T cells to help go after the cancer cell. And so, yes, we're fortunate that whether it's through the cooperative groups, something called the Big Ten Cancer Consortium, obviously a lot of investigator-initiated studies, we love the collaboration to do these studies together, to whether it's newly diagnosed, relapsed. The hope is, can we get more targeted therapies, more personalized treatment, obviously better outcomes, and if we can at the same time, less side effects is the goal.
Absolutely. Better outcomes and less side effects. From the patient point of view, that's really the holy grail you're looking for. You want to cure them with the least possible side effects, if possible.
Fantastic. Well, I'm getting the signal that we're right at 20 minutes and we want to be on time, as we always hear at Rutgers Cancer Institute in New Jersey. So again, if you're in the area or if you're nearby, please feel free to come by. It's open to the public at 195 Little Albany Street, our educational forum. There'll be a discussion on CAR T. Actually, one of our CAR T patients will be speaking at the event tonight, so I'm really looking forward to that. And if there were any additional questions that we didn't get to, please feel free to send those through on the social media platforms. And again, thank you very much for joining us.
Thank you.